Hello, and welcome to the continuation and final presentation from our virtual forum, How Collaborative Care Enhances Your Practice and Increases Child Mental Health Access. Today's session will be Leadership and Advocacy Across Systems. My name is Suzie Nelson, and I am an associate professor at the Wright State University Boonshoft School of Medicine, Department of Psychiatry. I currently serve as the program director for the general psychiatry residency here. And my clinical role is at the local children's hospital here in Dayton, Ohio, Dayton Children's Hospital, where I serve as the director of our integrated behavioral health services. So collaborative and integrated care is very much close to my heart and close to what I do on the day-to-day, and is a strong area of academic and teaching interest of mine. And so I'm really excited to be able to bring to you a part of this series and to wrap up the series by discussing ways that you can really lead in this space and advocate for collaborative care anywhere that you are practicing. This is a joint effort through the American Academy of Child and Adolescent Psychiatry, Healthcare Access and Economics Committee, and also the Collaborative and Integrated Care Committee. We have been very excited as a co-committee effort to be able to bring to you some tools that we really hope will help you to enter into this space and demonstrate that there are many levels at which you can participate in collaborative care programming, and that this is definitely reachable within your own practice settings, and that this will be a very useful toolkit for you as you approach that. Our series has been 6 asynchronous sessions. At the very end of today's presentation, just because this is our final virtual session in the 6-part series, I'll be talking with you a little bit more about some of what to expect next by way of further resources that we will be providing for you throughout the coming year as we approach the entirety of this program. But what we have offered to you in this 6-part series have been asynchronous sessions, and today's will be the final session focusing on leadership and advocacy across systems. These are our learning objectives for today. At the conclusion of this activity, you'll be able to better discuss methods to effectively advocate for funding and infrastructure requirements that will support collaborative care within your local system. You will also be able to identify and partner with stakeholders across systems for collaborative care advocacy, and promote advocacy strategies that can influence state and national levels for the furtherance of collaborative care practice. The first thing that I wanted to open up this particular session with as we discuss this is the idea of change management. In the book, A Systemic Approach to Behavioral Healthcare Integration, Context Matters by Nancy Reddy and Susan McDaniel, they cite J.P. Cotter's work on leading change with the Change Management 101 primer. Any system is going to have its own preferred manner of operating, and when we introduce collaborative care and integrated care models into these systems, these are essentially small disruptions to those preferences and habits. What we bring is a variety of methods for change that are beneficial to patients and families, both individually and at a population health level. But it is important to understand that by asking a system to change, we need to know how that change management will occur and how we can better develop that change. So oftentimes, change management begins with some identified sense of urgency for the need to change. We can all agree that we have an access to care crisis for child mental health services that seems to span nationally, and that we need to be able to do something to address this access to care concern. Oftentimes, once we have identified that urgency for the need to change, we want to then create some coalition to lead that change. This coalition of people can often have sort of a shared initial idea or dream of what can occur in order to achieve the necessary change. And those things can become more specific by the development of vision and strategy to achieve the change. Next, you and your team would want to be able to communicate that vision for the why, what, and how of the change. And this is a process by which you can inform others and invite others to be a part of the process for change. You can empower action so that others can begin to achieve that change. Prioritize early short-term wins with early successful change. So early victories in the process of change are very important so that people can begin to feel like, hey, I'm doing something about this. I seem to be moving the needle a little bit, or I feel like that the ability to move the needle on this access to care crisis is really within our reach with the change that we are achieving at this point. And those early short-term wins are a really important part of inspiring further change. You want to build on those early successes in order to produce momentum for more change, including developing more change agents who may be really interested in joining your team. And finally, we want to anchor innovation in the culture. In order to be able to achieve change in a lasting and sustainable way, we need to cultivate that support for long-term success and really institutionalize the change. Remember that there was a system that existed prior to the change coming into place, and that system had previously achieved its own homeostasis, that it had, even if it wasn't a complete degree of satisfaction, it had some degree of at least being used to it. And change being disruptive is going to essentially disrupt that homeostasis. So there will be times when everyone in the system may feel that it's more comfortable to return to where they were before. But what we want to be able to do is create these short-term successes that can evolve into long-term successes so that we can institutionalize some degree of cultural change that will essentially create what is a new homeostasis and what is, we hope, a much better model for care in the future. Now, how do we obtain and then maintain that buy-in with folks? Well, business and marketing have an acronym that we can resource to help us advocate for change. So we remember from virtual session number 2 with Melissa Hopkins that we saw the importance of identifying those stakeholders and obtaining that buy-in. And this is not a one and done step only at the beginning, but is definitely a continuous process when advocating for our collaborative care models. So this WIFM acronym is the what's in it for me. And when we think about being able to answer that question of what's in it for me with any given set of stakeholders who could potentially partner with us in this change, we want to ask ourselves, how can we tell a story in a way that will engage with those stakeholders to be able to produce the change that we're looking for? Our story matters to multiple groups of people, and this is actually sourced from a behavioral health integration compendium that you can access through the American Psychiatric Association and the American Medical Association that lists off some ideas for some of the potential stakeholder groups who may value this change. But most of us would agree that these are definitely groups that we may want to target with this idea of change. And as we review each of these groups over the next several slides and ways that collaborative and integrated care models can be of benefit for children in ways that are obvious to all stakeholders, you should consider your own area of responsibility. What are the ways that these messages speak to your patient populations and inspire you to bring this care to your own area? As you begin to deliver your story to potential stakeholders, we know that pediatric primary care clinicians and their clinical support staff are going to be key and critical stakeholders in this process. You may practice in an area near a large academic center or a metropolitan area where there seems to be better geographic access to care, but the demand exceeds the supply. You may practice in areas that are geographically separated from specialty mental health clinics. These priorities matter to our pediatric primary care colleagues, and so this can be an important part of the story that we share together in furthering our desire to increase access to mental health services for children. Everyone can agree that we want to be able to deliver more efficient, equitable mental health care to children in settings where access to specialty outpatient mental health referrals are limited. We also want to see improved outcomes for mental health concerns. Pediatric primary care clinicians will often identify that particulars about access to training resources, either when they were in residency training or follow-on clinical training, or even some of the follow-on resources that they may have access to in their careers, may not fully fill the gap of confidence and competence that they can feel to be able to address mental health concerns. And so the story of collaborative care and integrated care services is also about being able to improve that confidence and competence. Depending on the primary care system that's in place, we want to be able to see greater effectiveness and efficiency in care that may be a quality initiative that incentivizes a population-based approach. So value-based payments that are a part of these quality initiatives can help to invest back into the primary care practice. And all of these steps together can improve satisfaction at work and decrease burnout. If our clinical staff that support pediatric primary care colleagues also will see that it can be very distressing for families not to be able to get access to specialty mental health services when they need it, non-clinical support staff will often experience the same thing. Folks who take care of registration and scheduling within systems and frontline staff that manage phone calls and referrals know the agony of listening to distressed caregivers who cannot find these services. Non-clinical staff also often have the access to information about long wait lists, and they are aware that they are in a position of liaising between clinical staff, leadership, and families because of this access to information about how long wait lists may be. And these stories impact the quality of care perceptions about clinics and hospital systems. Our story also matters, obviously, to patients, their families, and their caregivers. There's an existing trusting relationship with a pediatric primary care clinician and a lot of comfort as care remains in a familiar practice setting when it is appropriate to remain in that setting. There's often less stigma involved in seeking mental health care within the primary care setting. More efficient pathways to mental health care lead to better outcomes, faster than specialty referrals alone due to the wait times that it takes to get into the specialty mental health clinic. This adds up to improved quality of life for the child and for the family that cares for the child when we're able to better meet that need. An earlier mental health intervention at less acute stages helps families that care for the child to return to and remain at work more often. Ultimately, this will result in less financial strain on the family and its entire system. Now, these frontline, more direct relationships that we have with patients, families, and our pediatric primary care clinicians and the staff that support pediatric primary care centers are obvious sources at which our story about collaborative care matters to others. But there are definitely less direct and what feels to some people like more peripheral parties that also have a stake in being able to improve access to mental health care for children and families. So our story also matters to payers. Early intervention, when mental health conditions are able to be identified sooner in the process and patients can achieve treatment success earlier in the process, ultimately leads to lower financial burden and cost of care in the long term. Successfully treating mental health conditions earlier and prior to the more critical or acute stages of illness results in less expenditure on the highest cost settings for care, such as emergency room visits and inpatient hospitalizations. We want care to occur at the right level and with the best evidence-based treatments available, and payers want this as well. And finally, to quote Tristan Garindo from the discussion in part 5 of our series, access, access, access. Payers really want the patients on their panels to be able to get access to evidence-based mental health care at the right level. Often, when we think through the stakeholders that we really want to be able to communicate and advocate to for increasing the ability to do collaborative and integrated models, leadership will be heavily involved in that support. It is important to leadership to be able to improve access to mental health services and also to improve health equity. When employees at a particular health system are able to achieve care and access in a more effective and efficient manner, and when there's greater satisfaction among employees throughout the system and also patients and their families, we often will see that improved work satisfaction. And improved work satisfaction reduces burnout among clinicians and staff, improving employee satisfaction overall with the system in which they work. And this increases the likelihood of employee retention. Leadership is also obviously concerned about making sure that from a revenue generating and budgetary standpoint, they're able to take care of their buildings, their employees, and all of their support staff. So being able to build services that can generate revenue will definitely speak to leadership. It may not be the absolute most important priority in everyone's mind, but it's definitely one that needs to go alongside all of our other priorities for improving access and improving equity. Collaborative care model, in terms of that former COCM, is an example of an expansion of billable services that can generate revenue for facilities. Additional sources of revenue can come from value-based care incentives. So when we achieve better quality care and we have measurable improvement in access to mental health services and lowered burden of high-cost interventions like hospitalization, this often will result in value-based care incentives that can be invested back into practices and clinical settings for future endeavors to be able to take better care of an overall population. Additionally, improved adherence with requirements for accreditation for patient-centered medical homes and federally qualified health centers will also be an incentive that matters to leadership. In addition to all of these various stakeholders, when we really think outside the box for all of the services and systems of care that exist to support children and families, we recognize that there are many partners in this care, and all of these partners tend to be very invested in ensuring that children's mental health needs and improving access to quality mental health services are definitely a priority among all of these shared groups. These may include schools, foster care and their organizations, juvenile justice systems, and community organizations. Each of these partners would like to see improved access to mental health services for children for whom they provide education, safety, and quality. Early intervention improves outcomes with downstream benefits for all of our systems of care partners. Now, what we want to do here, after considering all of these ways in which our story of collaborative care and what it can do for the entirety of the healthcare system that supports children, is to look at what we think is the difference between collaborative and integrated care and the care that has existed through our specialty mental health referral system previous to launching collaborative and integrated care models. And really, what we discover with that is that the population-based health approach to mental health care for children is where we want to see improved preventative services. What I have illustrated here is what we often think of as the prevention pyramid in public health. And when we start to take a look at mental health and the mental health care provision arm, we see that we can take public health and population-based approaches to mental health treatment and prevention of further challenges that come from not addressing mental health needs sooner in the process. Tertiary care is a really important space in what we do with mental health services. And the majority of us who practice in specialty mental health services are used to being able to practice in this tertiary prevention space, where most of our strategies are designed to address disease that's already in existence. And what we really want to be able to do with that is prevent morbidity and mortality. Collaborative and integrated care is really focused a little bit more in this secondary prevention space, wherein we want to be able to screen more widely to detect disease in early and easier to treat stages. And the interventions are delivered as close to the point of the identified clinical concern as possible. And so by bringing collaborative care and integrated care models into the pediatric primary care space, we do better at being able to achieve this secondary prevention space in mental health care delivery. Now, bear with me for a moment as I talk with you a little bit about taking this prevention pyramid that represents how we often look at things from a population-based standpoint. And we superimpose that on what we call a stepped care model in mental health services. And as I ask you to bear with me, I would just say, forgive some of the limitation that we can't always achieve in a two-dimensional model with something that's as complex as the entirety of the mental health service compendium here. But what we see is that the idea of the stepped care model is that at lower rungs of a ladder that are essentially more achievable by wider and wider portions of our population, we should be seeing lower acuity and we should be seeing less intensity of service requirement. And so what we want to be able to do in that space is to get to as wide an area of the population as possible with all of our primary prevention sorts of strategies, interventions that are designed to prevent the development of disease in the first place. Certainly, we know that many of our community-based and school-based prevention organizations will also get into the secondary and even at times the tertiary prevention space, depending on the acuity that's presenting to them. So the model here that I present is by no means, by no means includes any absolute demarcations of where people practice in their spaces. But oftentimes when we look at ideal delivery of care across a population, we want to be where the children are as widely as possible to deliver primary prevention strategies. And we want to be at these places where we more often will find children presenting for medical needs in order to get into the secondary prevention space. So patient-centered primary care with behavioral health integration is the perfect place to include collaborative care models, the primary care behavioral health model, and child psychiatry access programs as examples of ways to get into this secondary prevention space better, where we can identify illness earlier in an easier to treat stage, and we can implement greater and greater screening strategies so that we can detect illness in that earlier space. So when we think about the stepped care model and the place that these preventative public health models can be superimposed on mental health services, we see that on the continuum of care, by being integrated into pediatric primary care, we're able to achieve that secondary prevention space in a much better way. In addition to this, we all know that part of improving access to mental health services for children is about achieving better health equity. Integrating mental health services into primary care improves equity through provision of care that's ultimately closer to the patient's community. More families access primary care clinicians closer to their home or the child's school compared to their abilities to access specialty mental health services, particularly in areas where geographic separation exists from these subspecialty settings. So by being able to achieve care closer to the home setting, this improves care for families who face transportation barriers to travel to specialists. Additionally, there's also greater opportunity for cultural sensitivity. So a given community will often have a shared experience of unique challenges that the community may feel very invested in being able to support what is local to them as much as possible. So when patients, families, primary care clinicians, and integrated mental health clinicians are located and potentially even live in the same community where all of this care is taking place, there is often this greater opportunity for empathy and identification with some of the challenges that the community is facing. We also want to include in our story some outcomes. So when we go back and we think about that first slide from this particular presentation that spoke to the concept of Change Management 101, and we talked about the process of moving from early successes to later successes within our program and being able to build on those successes to propel further change and then come back into the system to reinforce some of what needs to happen in the culture in order to sustain that change. We also know that outcomes are a really critical part of propelling the message and the story. So in looking at potential outcomes, there are multiple areas that we want to see whether we can achieve some of these aims and goals in order to be able to demonstrate data and outcomes that support our model. So these may be population-based. They may include patient and caregiver satisfaction over the whole of the population that the pediatric primary care center is treating. For your students and families, you may be able to keep track of things like missed days of school or missed days of work through a self-report measure. And if you can demonstrate decreases in these missed days, particularly by comparing some time at present to a time in the past when these services were not available, this may be a way to demonstrate benefit over the course of, over the whole of the population. Medication adherence or improvement in any health status for those with chronic conditions can be another measure that you can look at in your clinical population in order to help demonstrate outcomes. Clinician-based outcomes are also important. Clinician and staff satisfaction, changes in efficiency for time spent in appointments may be ways to demonstrate the benefit of this for clinicians. Certainly things like benefits for access and equity, decreasing times to that first behavioral health contact and follow-up, especially compared to a prior treatment state that was based mostly on referrals and had longer wait times. The demonstration of that decreased time to contact can be very profound depending on the model that's used. Mental health service provision near patient zip codes that we had just talked about, and the ability to actually demonstrate that this is happening on a higher frequency basis supports the goal of health equity. Additionally, there will be revenue-based and savings-based types of measures that you can speak to that support your program. You will likely have a certain productivity based on direct care billing when utilizing primary care behavioral health and formal collaborative care models. Or there may be value-based incentives due to the cost savings and greater compliance and adherence with evidence-based practice. So all of these areas are potential areas where you can gather data and begin to track outcomes that can help propel your message. When we think about why all of these things are important, stories, data, communicating the message, being able to manage change appropriately, all of this adds up to advocacy. As we've discussed throughout the series, relationships are very critical to beginning, developing, and sustaining collaborative care. With whom do you have relationships that are potential areas of influence, and how can you advocate in ways that you have the ability to follow? So where do I have influence and bandwidth is a very important question to ask yourself at the outset. Depending on the model of collaborative or integrated care that is being delivered in your particular area or that you're beginning to look at that could be of benefit for the population that you treat and the population that is within your area of responsibility, are there stakeholders with whom you have influence and bandwidth in order to be able to get that buy-in with them? As you build on those relationships, and certainly as you achieve some early successes, you'll discover these common shared spaces where goals and aims can be set with those stakeholders. And those areas of influence and the bandwidth that you have to be able to pursue those areas of influence are definitely spaces where you want to look first for kind of low-hanging fruit to be able to build those relationships in order to propel what you want to do with collaborative care models. So in the practice setting where I am, as we began to launch collaborative care, we discovered that there was a subset of our pediatric population that was essentially that fit into a foster and kinship care clinic. And one of the things that we've been able to do with our own local integrated behavioral health model is ensure implementation of 100% primary care behavioral health contact when we have intakes into our foster and kinship care clinic. That is a high-risk population, often with a lot of ongoing stressors and obviously a history of trauma. And being able to identify behavioral health needs earlier in the process helps us to be more proactive to meet those needs, rather than having to be reactive at a time when a present placement may be in threat of disruption. So if we can avoid those acute presentations and avoid those crises by ensuring that we have some sort of behavioral health contact at the onset of care in our foster and kinship care sub-arm of the pediatric primary care setting, that's a way for us to help that patient population, help the local child protective services agency and the foster agencies that are in the area, and helps us to be able to identify and partner with someone who can essentially deliver a similar advocacy message as we deliver when they look at their spheres of influence. So when you look at the ways in which, as a clinician, you have a sphere of influence, and then you identify these influences in your community, and they have spheres of influence, well, you can begin to see how those spheres may come together in this sort of like overlapping Venn diagram way. And where you have these common spaces, there's often the ability to influence others to perpetuate the change that you're seeking. Additionally to that, you probably have a shared identifiable problem when you consider those with whom you have influence. And once you identify a key problem, like the national crisis for child mental health access, you can then propose the solutions that meet this "what's in it for me" test that we talked about earlier. Advocacy involves identifying potential local advocates. So those local stakeholders that I just mentioned that may be easy spheres of influence that you can reach out to first. Perhaps you are empaneled with multiple payers and you can engage with them on ways to improve the ability to bill for collaborative care codes in your area. You may have influence at the level of state departments of Medicaid or insurance. And if you find that maybe those areas of influence are not completely obvious to you today, or you have a few and you're trying to figure out elsewise how you might get started, I would encourage you also to reach out to your ROCAP or your APA district branch so that you can identify other people with these shared goals of meeting the need of lack of access to child mental health services through collaborative and integrated care. As you begin to approach the idea of how can I advocate better, you want to think through things like, what is your elevator pitch? So depending on the audience that you might have access to, you may be able to do things like cite wide statistics about that national crisis for child mental health access. But do you need information about this at a level that's more local to where you are? What do those numbers equate to for your state? Or if there's a particularly limited access region of your state, especially if your audience represents or influences decisions in that part of your state, like a state legislator, could you write something to them that goes after the ability to support collaborative care models in your area? Could you write an op-ed or a letter to the editor or a blog post? These may be kind of, bandwidth reaches that are easier for some people that have influence in their local areas. If you write an op-ed for your local paper, and the local paper also has a website, and your op-ed is accessible there, that suddenly puts your name and your face at the forefront of the kinds of things that matter to people. And that may get the attention of a multitude of people, whether they be patients and families, kind of at that basic level, who may recognize you as a care provider or may recognize the pediatric offices that could partner in this effort. but it may also influence other people in these stakeholder agencies that we had talked about. Your local juvenile justice agency, your local foster care agency, or people who have influences over the kinds of care services that they may want to be able to provide in their school system. Government officials and local elected officials may also read your op-ed and see that, hey, child mental health care is really something that I should care about too. And maybe there are ways that I can invest energy into that. Could your partnerships with stakeholders be a key part of your advocacy for collaborative care so that you can further the aim of improving this problem of lack of access to child mental health services? Finally, one of the things I want to leave you with is an encouragement to visit the ACAP Advocacy Toolkit. All members have access to this toolkit on the website. And while a full review of every aspect of the toolkit is beyond the scope of this presentation, I will just show you that when you look at this, really nice visual here for the representation of the advocacy toolkit, you see all of these different individual pictures. And actually, when you progress through the toolkit, every one of these pictures is an icon that links to a different skill set that you can exercise as a part of your journey of advocacy. Advocacy isn't about always making a trip to the state legislature, although it could be. But things like making sure your voice is heard, developing your elevator pitch, how to write letters appropriately, how to track data and outcomes and be able to communicate that in ways that matter to the people to whom you need to advocate for this change. These are all skills that you can find some helpful tools for within the toolkit and that you can develop yourself. And definitely are things that are within reach for all of us who are practicing in child mental health, where we have this investment in where we want child mental health access to go. That concludes our presentation for this session, Leadership and Advocacy Across Systems of Care. And I'm very, very glad that we have had this opportunity to share these 6 collaborative care virtual sessions with you. I really hope that you have been able to watch through these, enjoy them, download the slides and all of the references that are available therein. Some of the slides were definitely full of a lot of information, and we do encourage you to download them and to really use them to essentially build your own toolkit toward launching collaborative and integrated care models within your sphere of influence. We've gone through collaborative care, why we do it, why we love it, for those of us who practice in this space, given you some ideas for and very practical tips for how you can get started with building your team and how you set the stage. We've discussed the importance of cultivating productive relationships, particularly with our colleagues in pediatric primary care and our regional mental health partners. We've discussed the importance of the use of measurement-based care in order to be able to work with clinical registries for those of you who choose to practice in the collaborative care model. And we've gone over the process for how you can establish value and secure funding for your work in very practical ways. And finally, with the session today, we've spoken to the idea of change management and being able to advocate for that change to launch collaborative and integrated care models in your area in order to meet the aim of improving access to quality child mental health services in a much more equitable way. So we're very, very happy that you've joined with us. We encourage you, if there are any sessions that you hadn't had a chance to see yet, to please go back and take a look at those and make use of all of the tools in this toolkit for being able to get into this space and advocate for this space. Our mission as a part of this virtual fora has been to help child and adolescent psychiatrists like you and me understand and expand our potential for providing collaborative care in the pediatric medical home. We have launched this at the onset of 2025. These 6 sessions will be accessible to you as members of ACAP for free, and you may get to them at any point kind of at your leisure and review them when you would like to do so. The next steps in this process, after going through our asynchronous virtual fora series, will be 3 live opportunities to interact with other child psychiatrists. Most of us who have been a part of this virtual fora will be available at 2 virtual sessions, and what we really hope will be a live in-person session at the next ACAP annual meeting in October. These virtual sessions and the live session in October will be designed as a very reachable question and answer session where we can go over the information in the fora and address any additional questions that you may have. Some of you may be in very different stages of considering practicing in a collaborative or integrated care model. You may be considering it and thinking through how you could get involved. You may be at the beginning of setting up a model. You may be well into your model and want to be able to think through how can I collect data and outcomes in a more effective way. And no matter where you are on that continuum, we encourage you to join us for these sessions so that we can all discuss together ways that we can further collaborative care in order to enhance your practice and increase access to mental health services for children. I want to ensure that I deliver a lot of thanks to all of the partners with whom I have had the privilege to work for our virtual fora series. This is the oversight committee that has been involved in the development of this virtual fora throughout. It's definitely been a labor of love for all of us. And a labor of really looking at how we can bring some practical tips together for a toolkit for all of you. And so I want to thank all of the members of the Oversight Committee. And these are going to be the names and faces that you're of greater likelihood to see again in our follow-up live sessions. And finally, I also want to give special thanks to some specific ACAP staff who are listed here, all of our ACAP leadership, and the videography and editorial team. We were very eager to be able to take what we do and what we feel a passion for in collaborative and integrated care models and deliver it in a practical and reachable way for all of the membership. And we would never have been able to do this without all of the help and support from the Academy and all of our Academy staff. So thank you so much. And thank you to the audience for being here with us for this virtual fora. We look forward to seeing you during our next Q&A in the March timeframe. Bye.